Good morning, everybody. And as usual, giving a second for people to hop into the our Grand Rounds attendees. Thank you for joining this morning. Right before we get started with our usual updates, we have quite a few updates and, of course, a really interesting, exciting presentation from Dr. Damrose. I want to send out, and I'm going to send out the links, a couple shout outs to a couple fundraising projects, one of them being done by our own chief residents, Mita, Adrian, and Andrew. They've been leading this fundraising project that's basically, they call it Residents Helping Residents, where they're raising money for food insecurity through the Second Harvest Food Bank. And I'm looking up there now, they're almost at 80% of their initial goal. So we're looking forward to hitting that goal and perhaps blowing right through it. So I'm going to send a link through that. And the second one is Dr. Minchi Tran. She's one of the hospitals at Valley Care Hospital in Pleasanton. And I don't know if some of you have seen the article we highlighted in our last annual report. It's called the Wish Project, where essentially they're doing this amazing project where they provide a wish for someone who's basically terminal, and they provide just some of the most amazing stories we've seen in regards to patient care. I'm going to send a link on that so you can learn more, including the article we highlighted, and there's a video as well. So there's a couple fundraising projects. Dr. Tran's going to fellowship, and the last thing she's doing before she moves on is trying to raise enough funds to keep this project going over at Valley Care. So I'm going to send those two by. Thanks for those of you who have already donated, and they're both tax deductible as well. I'll turn it over to Dr. Collins now for the first of the updates.
Right. Can you see everything?
Yeah.
Yes.
Okay. So I'm going to briefly update where we're at with COVID-19, and then I think a couple other folks are going to talk about the response to some of the numbers. So, please move forward. There we go. So I think we're all pretty familiar with these curves showing new cases, hospitalizations, and deaths. You can see the inflection, especially for November, is quite striking for all three now. There is this little tail here in the new cases and new deaths on these curves, but the thought is that this was actually because of less testing during the Thanksgiving holiday, and the concern, which was expressed by Dr. Fauci on one of the Sunday shows, is that we're going to see now a surge superimposed on top of this surge because of the travel and the holidays. He did reiterate that it is not too late for all of us to do something about this. I think some other folks may speak on things that we can continue to do about this, but basically in terms of being good clinicians and good citizens to try to continue to do the public health things to prevent this from getting worse and worse. Looking locally at our Bay Area counties, this is hospitalized patients per 100,000. And I didn't even circle it because it's pretty clear. Basically, every county curve is going up and at a pretty striking rate. And I think we're all aware now, we're all, except for Marin County, now in the purple tier, and we're really accelerating into the purple tier, most counties, especially Santa Clara County, which you can see here. This is from their county health website. And when you look at the acceleration, which was blocked there for a second for me, but you can see, especially going into November, the rate of new cases, and this gray area is incomplete data. So expected that will continue to show an increase and a pretty striking rate of increase. For Stanford, this is showing new positive cases by week and new hospitalized by week. We're also now seeing the increase. You can see it both with positive cases, and then for hospitalized per week, the last week looks to be, at least for the numbers we have, the most number of new hospitalized in 1 week. So definitely we are part of this as well. And looking at our census, you can see that for COVID positive and for ICU, those are both going up pretty steadily here in recent days and weeks. For the demographics, the numbers are pretty much the same, just higher, but the percentages are about the same. As of last night, there were 27 COVID positive in the hospital, with 8 in the ICU and 3 in the ED. And I'll leave it up for just a second longer if people want to look at the other demographics. But as I said, they're pretty much the same, just the numbers are higher. So with that, my computer is going a little crazy on me. I apologize, but I was going to end there. I just need to find my cursor so I can allow the meeting to move forward.
No problem, Will. Thanks so much as always for providing these updates.
There we go.
And great, thanks so much. Moving over for Dr. Huja. Dr. Huja is providing us information, the surge planning, and also really up-to-date information as available on the vaccine planning as well. I know a lot of people have been asking about that, and we'll continue to keep you updated when we have the information. Thanks, Dr. Huja.
All right. Good morning, everyone. It's nice to be back and provide you with some updates. So as you know, SHC is in constant communication with the state and the local counties about capacity. We want to make sure that in addition to taking care of our own patient population, we support our community. So anticipating that the ICU capacity will definitely be exceeding in the next few weeks, as it has been in some of the surrounding hospitals, we are collaborating with each other. There are people, CMOs, talking to CMOs at other hospitals to make sure that we have a very good and equitable triage system, and balancing not only from the local Bay Area, but the Southern California counties as well. So for example, Imperial County has reached out to us both earlier in the spring, and again, we're working with them to help their area out. Santa Clara County, as you saw from Dr. Collins' slides, has really exponentially grown with the number of COVID patients. And unfortunately, we've exceeded our previous peak and are anticipated to continue to go up. Valley Care has also seen increased numbers. Yesterday, they had 6 COVID patients. 2 days ago, they had 11 COVID patients. So their numbers are higher, but proportionately lower than SHC, just because their overall volume is smaller. Now, as we look at the surge planning attempts, we need to look at them both in the ICU and on the wards. And with the current numbers, our current staffing is stable. We have an existing infrastructure with the 6 medicine house staff teams. And, we are really trying to be protective of the house staff, not having them go in to see the COVID patients. The hospitalists do that. But thank goodness for the Zoom room, which really allows for us to communicate with the patients safely, keep them up to date without having to repeatedly dawn on and dawn off and go into the rooms unless a physical exam is needed or there's some sort of intervention or procedure that needs to be done. Should the numbers go higher, and we are anticipating that they would, we have a 2nd or 7th team that would come on and, utilizing APP to help, that would also then staff another volume of patients. Should the numbers continue to go higher, or we suffer from provider loss, and this is a true concern. We have had several providers exposed to patients that were maybe not initially known to be COVID positive, but then converted COVID positive. Fortunately, with the just standard masking protocols, none of the providers have been, in our group at least, have tested positive. Good. But we do want to make sure that we account for any potential exposure, both in the community or in-house. So if that were to be the case, that we had high volumes and low provider staffing, I'm just so delighted to say how incredibly collegial our department has been. And we've had many people step up from other divisions to provide backup staffing. And keep in mind, this is different from March, because in March, April, the overall volumes were low. Now our non-COVID volumes are high, and we have holidays coming up. Yet we do have these commitments from other divisions, so I thank them. And then the 4th phase would be, if volumes really skyrocketed, we anticipate that surgical cases would potentially be canceled. They're not canceled at this time, but that they would be. And so we have our surgical co-management hospitals that could help out. So I think we're pretty well prepared for the worst, but we'll hope for the best. And then moving on to our ICU, and I really want to commend and acknowledge the leadership of Ann Weinecker, Angela Rogers, and Arthur Sung in the planning for the ICU surge should it happen. The volume has risen enough so they have a 3rd or expanded ICU team, and they have actually high numbers of both COVID and non-COVID patients to account for. And as we saw from Dr. Collins' slides, up to 22% of the ICU volume ICU volume could be COVID patients. In addition to that, with the help of Steve Ruas, the transfer center protocols have been very scrutinized and defined such that we do help our local community both to allow patients to come in for treatment and potential enrollment in clinical trials. And this has been a really collaborative effort between medicine, anesthesia, and our emergency department. Just a few words about the vaccine distribution and timeline. And this is the latest information. As it evolves, we'll continue to keep you updated. But the Pfizer vaccine is the vaccine that's planned to be administered. There's a few phases in which it would be distributed. And phase 1A would be a limited supply and would focus on high-risk healthcare workers. So very frontline COVID-facing healthcare workers, first responders, and high-risk populations. And we have about 16,000 healthcare workers in the institution. Phase 1A may be able to incorporate about a third of that, up to 5,000, but it really depends on how much of the vaccine is delivered to us. We may be able to start administering this by as early as about 2 weeks. So that would be a very optimistic timeline. Phase 1B and 2 would start in late December, early January, and this would include the more high-risk populations and the more expanded healthcare worker plan. And most importantly, Stanford will definitely ensure that there are ethical principles for vaccine prioritization. So looking at how we optimize the overall benefit, prioritizing the high-risk patients, making sure there's equitable distribution and transparency, having community engagement in the process, and obviously having respect for the patients throughout this process. So with that, I will stop my screen share and happy to answer any questions on the chat.
So moving on, I just want to briefly mention next week we have a Dr. Lynn Chen, who's the president of the National Society of Travel Medicine, who's going to be talking about travel in the era of COVID-19. Hopefully travel is being limited right now for your safety, but she's going to talk about that. And that will be our last grand rounds for 2020. And we'll start right back up the first week of 2021 in January. So now I have the esteemed pleasure to welcome our main presenter today, Dr. and Captain Ed Damrose. Dr. Damrose finished his fellowship in laryngeal surgery at UCLA in 2003. After that, he came and joined us and has been a Stanford faculty since then. He's the current immediate past chief of staff at Stanford Healthcare after serving as chief of staff for Stanford Healthcare from 2017 to 2020 and vice chief of staff just before that. He's the director of the Fellowship of Laryngology and Bronchoesophagology. I totally just killed that word, from 2006 until now. And he's, of course, the chief of division of laryngology as well. He is also, as I mentioned earlier, a captain. He's captain in the U.S. Navy Reserve. I just want to mention and just say personally, Dr. Damrose, over the years, especially as a younger faculty, anytime I reached out to you as the chief of staff, you are always have been one of the most genuine and kind people to speak with, and it's such an honor to have you join us on Grand Rounds today. Thank you for your service, and thank you for joining us today to share your story, your experiences in Guam earlier this year. I'm going to stop sharing my screen so you can go ahead and share your slides. So thanks so much for joining us.
Well, Errol, thank you so much for that just incredibly nice introduction. It's such an honor to be with you all here today. I want to thank the Department of Medicine for the opportunity to share this experience, and also my colleagues in my department who were so kind to take up my clinical workload while I was away, and of course my chairman and friend Robert Jackler, who has always been supportive of my efforts with the Navy. So thank you so much. It's truly a pleasure to be with you here today. I really have there's no financial disclosures. I do have to say that the views you're going to hear here are my own and my own opinions, not really the representative of the Department of Defense. So please take that with a grain of salt. I wanted to talk to you a little bit about Naval Organization, just as a brief overview, what happened to the Roosevelt on deployment, a little bit about me as a reservist and about reserve medicine, and then more about the mission that we had in Guam and the fallout from that. Many of you might know, but there are several naval fleets that are spread around the world. The 5th Fleet is engaged in the Middle East right now. The 7th Fleet and the 3rd Fleet are assigned to the Pacific. The 7th Fleet, to which I was temporarily assigned, guards the region of the Western Pacific, and in particular has purview over this area of the world, the South China Sea, where I think we've all heard much in the news about this. This is an area of territory that's contested by numerous nations that border this area. China has set out an area of demarcation that they feel represents their area of national interest, but borders on a number of countries in this area that also have similar economic concerns. About $1 trillion of trade every year flows through this area. So it is an area of vital interest to many nations in the world, including the United States. the United States maintains a strike group in that area, Strike Group 9, which is centered around the USS Roosevelt, which is a nuclear-powered aircraft carrier, 2 guided missile cruisers, a destroyer squadron, and a carrier air wing. And it was to this strike group that we were assigned to help. The centerpiece of the strike group is, of course, the USS Roosevelt. She is a massive 100,000-ton nuclear-powered aircraft carrier. She carries about 90 aircraft and helicopters, is powered by 2 nuclear reactors, and can deliver herself more firepower than was ever delivered throughout the duration of World War II by all parties involved. So she's a very, very powerful vessel, very important as a member of the strike group. Her story kind of began around early in March, where she paid a visit to Vietnam. This is the command staff here pictured here. On the left is Captain Crozier, who is commander of the Roosevelt, Admiral Baker, who is commander of the strike group and also aboard the Roosevelt. And this is Admiral Aquilino, who is in charge of naval affairs for the Pacific and is currently under consideration for appointment as chief of Indonesia PACOM area of operations. Most people were not aware of this unless you follow military affairs or naval affairs, but the Roosevelt made port in Vietnam early in March. This was an important visit. It was only the second time that a U.S. carrier had made a stop in Vietnam since the 1970s. And at the time, as we all know, there was a concern about coronavirus spreading throughout the world, particularly in that part of the world, but it was felt safe enough for the carrier to visit. And so she made port. Most of us, I think, became aware of this visit when this story hit the San Francisco Chronicle. Most people that saw the story became aware that we had a very serious outbreak of COVID among the aircraft personnel. And the private message traffic that the commander of the Roosevelt had sent up the chain of command made its way into the press. And I think most people will probably remember this story and his comment to his superiors that we are not at war and sailors do not need to die. So a little bit more detail on that. Although the ship made port earlier in March, it was about 2 weeks after that port visit that the first sailor on board the Teddy Roosevelt was diagnosed with COVID. And as you can see down here on this graph, following the first diagnoses, the rates of infection just began to skyrocket among the crew, which had the medical staff aboard the carrier and medical personnel in the Navy very, very worried about what was going on. The Roosevelt made port in Guam, which is a very important naval base for us in the Pacific. Guam is a U.S. territory. It's been a territory since the Spanish-American War. The day that the Roosevelt made port, Guam declared the area as a disaster through FEMA. So this enabled resourcing of medical resources to the island, coincidental with the arrival of the carrier there in port. This is just a little bit of an overview of COVID on Guam. There's about 160,000 people, civilians, that live on the island of Guam. Earlier on in the pandemic, we saw rates going up quite a bit. The island really shut down. People could not move around on the island. You couldn't leave your homes or travel for unnecessary reasons. And with that restriction of movement in place, we really saw COVID come under control. And this was during my period here on the island. We really saw very little COVID change among the civilian population. After I had left and the island began to reopen to tourism, we started to see COVID increase. And now, just like around the rest of the world and here in the United States, Guam is also experiencing an uptick in cases. They've seen about almost 8,000 cases to date and about 113 deaths so far. This is a little bit of an overview of Guam. Guam is located in the Western Pacific. It's just north of the equator and just west of the Marianas Trench, which is the deepest part on the face of the earth. It's about 19 hours to travel by airplane from California to Guam. There are a number of major naval installations on the island, including Naval Base Guam, which you see here in the picture at the right. This is a very, very large anchorage for naval ships. Way out here on the peninsula, you can see the dock for nuclear-powered carriers like the Roosevelt, and this is where the Roosevelt was docked during my time here on the island. There's a large Air Force base on the north of the island, where all military traffic really comes in, and other important installations as well. So very important military base for us. By way of background, I've been a Naval Reservist for about 12 years. I affiliated with the Navy in 2008. I've had a number of just wonderful experiences around the country and now around the world. I've made some fantastic friends. I have to say that the quality of the people that I meet in the military, they're patriotic, very giving, wonderful people. It's just been my pleasure to know them. People often ask me how did I get involved in the Navy. I do have a little bit of a military background in my family. My uncles on my father's side were all involved in the military during World War II. My great uncle Edward was killed on the Wasp in 1945, and I'm named after him. Another uncle on my mother's side is a veteran of the Battle of Midway. He was a fighter pilot throughout the Pacific during World War II. There's a famous picture out there called Approaching the Gate to Destiny, which depicts the USS Hornet sailing out of the San Francisco Bay and under the bridge with Jimmy Doolittle's bombers on board. My uncle was on this ship and went with Doolittle, went with the Doolittle mission when they bombed Tokyo, and then he subsequently served at the Battle of Midway and throughout the Pacific during World War II. So I guess there is a little bit of a family background of naval service to which which impressed me and which also guided me to want to participate. Just a little bit about what I actually do now, so you can understand what resources we sent to Guam. I work with what's called an expeditionary medical facility. The old term is a fleet hospital. If you ever watch the TV show MASH, that's really what we are. We're a mobile hospital. The Navy calls them expeditionary medical facilities. The Army now calls them CASHs, Combat Surgical Hospital, but we are a mobile hospital. It's about 450 people are needed to staff a hospital like this. The main focus is on delivering surgical trauma care, although for our mission in Guam, we had to really turn this around a bit and specialize in delivering preventative care and infectious disease care. These hospitals can be outfitted for a variety of missions. At our largest size, we can provide a 150-bed hospital, 20 ICU, and 130 acute care ward beds. There are smaller versions of this which can be sent out, a 50-bed model, and then an even smaller model, which is called an expeditionary mobile unit, comprising 10 beds and 2 ORs. This is actually what I command under EMF Jacksonville. So this is the unit that I'm assigned to. These types of hospitals, they all share certain characteristics. They can be put together very, very quickly in a matter of days, usually with the assistance of our CBs. Our task is to become operational and start seeing patients within 72 hours of arriving on site. We carry with us our own pharmacy, ICUs, CAT scanners, OR tables, and supplies to take care of the patients. And these are structured to be able to resist chemical or biological or even radiologic devices for up to 72 hours. We can be self-contained within these structures and do relatively okay. These field hospitals are fairly large. This is a blueprint of what one of these things looks like fully set up, which we were in Guam. It spreads over 13 acres. These little individual structures are tents called temper tents that have to be set up by hand. The hospital itself is connected by corridors and tunnels and can be completely sealed off from the rest of the environment. It's actually massive, and I'll show you some pictures there. The staff is usually quartered somewhere away. We were about a quarter of a mile away on our own staff housing, and there are showers and latrines and laundry facilities provided for the staff, as well as a galley and fuel storage to actually run the generators for the hospital. All of this equipment is put into shipping containers, which are then sent via ship to where we need to go. By way of familiarizing you with where we are in the algorithm of military medical care, you can think of it this way. On the battlefield, people that are wounded may need to care for themselves or care for a friend, and we call that self or buddy aid. There may be a battalion aid station, which is like an emergency first aid station set up. But the goal is to quickly evacuate somebody who's wounded back to a higher level of care and control life-threatening hemorrhages, life-threatening injuries such as hemorrhage or pneumothorax, et cetera. And so folks that are wounded on the battlefield may be evacuated to what we call a Roll 2 facility or a shock trauma platoon. From here, they're stabilized and would be sent to us, and we provide actual hospitalization on the battlefield in theater. This is a picture down here on the right of my hospital set up in Guam, and you can see how large it is. This is where we would actually hospitalize wounded or injured patients. The equivalent in the Navy is a hospital ship, which you see right here. A hospital ship can actually hold up to 1,000 patients on board, so quite a bit bigger. But hospital ships and EMFs allow us to provide hospitalization and care for people that are wounded actually in theater. This shows a little bit about what happens to a wounded person. Our goal is to try to get them out of the theater as fast as possible. Once they're evacuated from the battlefield and they're treated and stabilized with us, our goal is to get them to more definitive care, which may involve transfer to a higher level of care facility, a Roll 4 in a place like Landstuhl, Germany, which is where many of our folks have gone from the Middle East, and then get them stateside back to a major U.S. hospital such as the Walter Reed National Military Medical Center, and then on to a VA facility for rehabilitation. So this is kind of the pathway that we follow. As I stated earlier, I am in charge of an expeditionary unit. One of the things that we have to do annually is, or semi-annually, is to certify that we're ready to deploy. This is where we tend to do our field exercises at a training facility at Camp Pendleton. If you belong to a platform like this, you learn not only how to build the actual hospital, and this is all of us out on the field setting up the hospitals, but you need to learn how to set up the tents, actually how to put all of the components together, including setting up generators, the HVAC. We will take and set up our own equipment inside these units. And you can see here, this is a pretty much of an example of how our equipment comes to us in these containers. And so these are removed off of ISO containers, and we will set up our hospital. So all of the people that you see here are personnel assigned to this kind of a platform. And not only are they going to be providing medical care, but they're going to be helping to set up the facility as well. Once the facility is set up, we generally engage in simulation training with all personnel and run war games or other scenarios. Down here on the left, you see a gentleman wearing a cut suit, which provides training for and simulation for our surgeons and supply and other personnel. Moulage, the makeup is here to simulate wounds. We actually have fairly realistic mannequins that are robot controlled, that we can control blood pressure or bleeding and simulate injuries. Oftentimes there is a unit of referees or personnel that are judging our performance and giving us feedback. And we try to deal with real live scenarios that actually happen on the field. What happens, with injuries of, say, this severity? How are we going to manage this? And so after we've set up the facility, we war game. This was an exercise I was just at earlier this month to give you an example of all the things that we do. This is actually a dog. This is a robot dog. If a canine is wounded on the battlefield, it's our job to take care of the dog as well. And there are protocols in place to help us manage a wounded animal that might come in. So many people might be surprised to realize that, and we do have veterinary support out in the field. So kind of an interesting kind of situation. Just back really quickly to Guam and what happened. I know that many of us were busy trying to deal with the problem at hand. Around March 13th, there was a declaration of a national emergency, and then about a little over about 10 days later or so, the Secretary of Defense activated the Naval Reserve Medical Services in support of what was going to be called COVID-19 response, which was the mission not only in Guam, but around the United States to provide military care to other sites. And then because of the urgency of the emergency, it was a decision was made to withhold the advance notice that reservists normally get, informing them that they might get deployed. Reservists from the Navy went all around the United States. We sent, as you might recall, 2 hospital ships, 1 to each coast. And then many of our colleagues went to the Javits Center and went to New York to support the missions there. I was told that I was going to be going to New York as the commanding officer of my unit around March 29th. I was issued some warning orders there, but because of what was happening in Guam, I was redirected to join the EMF Expeditionary Medical Facility with Camp Pendleton and sent there in charge of surgical services in the ICU. And this was the first time that the Reserve had deployed a fleet hospital in support of the regular Navy since Vietnam. So this was a major undertaking that we hadn't seen in many decades. I reported at Camp Pendleton on and about the 7th of April, and then went to Guam with my advance party around the 18th. So this is me in Guam after we had arrived, and as I stated, I was put in charge of our surgical teams and then in charge of our ICUs. This is what Guam looks like as an overview. The main naval base is indicated here on the map. There is a hospital, naval hospital on the island here. The main airport for civilian traffic is located right here. And we had set up our field hospital right up here on the northwest corner of the island, just south of the main air base. Our supplies had come to us on a ship like this. This is called the Doll. She had all of our gear on board. This is her docked in Guam and offloading all of our equipment. It's amazing how much equipment is on here. This includes ambulances, forklifts, 150 ISO containers with all of our gear and everything needed to set up the field hospital. This is an example of one of the forklifts that's used to move the ISO containers around that actually have our gear, and some of the ambulances that came with us for us to transport patients around the island. Our mission on getting to Guam was the following. We were primarily there to support the crew of the Roosevelt, but also we were asked to prepare to support the civilian population on the island of Guam, and as a contingency to provide humanitarian assistance to friendly independent nation states in the area, such as Saipan, where we could. And this is important from a strategic point of view to build friendly relations with islands in the area. This was an article that appeared in the Stars and Stripes around September from some of our efforts on Palau, where they actually appreciated what we were able to do from a humanitarian perspective to the point of allowing us to establish bases there on the island. So we really had it was really a 3-pronged mission for us. This is an example layout of what the medical availability was on the island. We were stationed up here, and by bringing 20 ICU beds and 120 other beds, really augmented the available beds on the island. The civilian medical facilities were really not adequate, we felt, for preparing for what we thought was going to be a fairly large surge in patients with COVID. So this is where we were operating, and we were working in concert with the Army and also with elements from the Air Force Base to the north. This is the Roosevelt docked in port, and this is where she remained for most of our mission out there. This is an aerial view of our hospital, completely set up. The entrance into the hospital is right up here. This is where we would have patients enter, and then you can see that everything is interconnected through corridors, and our operating spaces were right back here. The ISO containers that our equipment came in, you can kind of see stacked along here. This was my operating room. This is one of 2 that we had set up. And as you can see, the tables are set side by side. In a trauma situation, each bed is designed to perform about 9 trauma surgeries a day. That's the expected turnover for each bed, and teams can actually work side by side if need be. This is what an example of the wings of our acute care ward looks like inside a tent. As you can see, the tents are fairly large and very roomy on the inside. They're air conditioned, but the beds are aligned, side by side with distance as best as we could allow for distancing between the patients. We have our own supplies, which are stocked. Again, kind of a view of how expansive these tents are on the inside. This is not like a regular tent you'd buy at Home Goods or wherever and go camping with your kids. They're actually pretty large and pretty expansive. This is a view of our trauma bay and our sick hall area. You can see as the gurneys kind of lined up along the side, and there's some patient care going on down here at the end of the tent. These guys were under my supervision. These are our these are our biomedical support guys, great guys. These were our sterilizers that were used to sterilize our equipment. They're old, but they're functional. We did have some issues with some breakdown, and it was interesting learning how to actually troubleshoot these things and to actually operate them. But that's one of the interesting things about the military that you get to do. You get to learn and do things that you never really thought you'd do on the civilian side. This is all of us during an inspection with the Admiral coming through. This is me in the background and some of the members of my team standing by. So what was the plan here for the Roosevelt? This is really this was the main game plan. They wanted to get the crew off, leaving the minimal people aboard that they could to run the nuclear reactors, disinfect the ship, and then get the crew well and get them back on board and get out to sea as fast as we could. And their protocol here was to nasal swab test all of the sailors. If they were positive, they went into isolation. If they were negative, they went into quarantine on some hoteling spaces on the island. They would, in order to get back on the ship, they did require that people be retested and actually be, as best as we could tell, negative before they were entering the ship. As we kind of know now, people may be positive for a long time, but at the time that we had actually gotten out there, it wasn't clear to us yet that might be the case. Those people that were COVID negative were maintained here on the hoteling space on the island. This is Tumon Bay, which is located just up here, just south of where we had set up our field hospital. Because the island had been shut to tourism, it worked out well for us that these spaces were free for our people to go to and stay there. COVID positive folks were kept in berthing, in group berthing. It wasn't the most glamorous or the nicest, and there were a lot of complaints about the facilities, but this is some of the spacing, the gyms that were available on the naval base, as well as some of the classrooms. You can see it's rather austere. It's not private. It's pretty typical from a military standpoint. This is where I was birthed, so not much different. We lived in tents for the 3 months I was out there. This is my bunk down here in the corner. This little field chair is great. If you ever go camping, get yourself a field chair. It really makes a big difference. As you can see, there's not a lot of space to sit down on a bunk like this. Those of us that participate in expeditionary medicine, we're used to this. This is our berthing at a field exercise several years ago. As you can tell, it's not much different. This is how we sleep and live and eat in the field. This was another exercise participating in Sam Houston. Similar situation, not much room for gear, not much privacy. If you're looking for privacy in the military, you won't find it. Typical latrine type facilities. So it is what it is. This is an example of what we ate while we were there in Guam. There are hot meals, and Spam is interesting. If you don't eat a hot meal like this, you get to eat meals ready to eat, MREs. I'm personally sick of MREs and hope I never see one again, but they are interesting and they do their best to make a variety for people to eat. On the island of Guam, it's rather interesting. It's very hot and very humid, very tropical. As I said, we're about 900 miles north of the equator. The daily temperature with the humidity is about 100 to 110 degrees. We were wearing full uniforms, which was somewhat uncomfortable with sleeves down, and you sweat a lot, but you do adapt. The typhoon season on the island is from June to November, and so this was of concern to us because we realized that we had a tent situation set up which would still be there during the typhoon season. So we had to make some adjustments to that. The island has been a part of the United States since 1898, and it was invaded and held by the Japanese in 1941 and then recaptured in 1944. You can go around the island and see the vestiges from the war. These are old Japanese bunkers and gun emplacements along the beach. So you can walk along some of these areas on the base and still see things like this. If you go out into the jungle a little bit, you'll find remnants from the war. This is some landing gear from a crashed plane lying out in the jungle. And this was the wreckage of a Corsair that went down. I had to go out into the jungle quite a bit to get this picture. And there's lots of mosquitoes around. Compounding our concern was the fact that we had an outbreak of dengue fever on the island as well. And the symptoms are interestingly very similar to COVID. So it was a concern to us that we were out there. While we were out there, fortunately, nobody got dengue fever, but it is interesting to go out into the jungle and see things like this and to realize that, wow, this has been out here for 70 years. So what actually happened to the crew? The Roosevelt had almost 5,000 people on board. 3,500 actually did not get COVID, but a little over 1,300 did. And this is the group here that we were charged with taking care of. Interestingly, only about 43%, 43% that were confirmed to have COVID were asymptomatic at the time. Only about 30% actually had symptoms of COVID and then were subsequently, 30% actually were COVID positive, but developed symptoms later on. About 22% actually had symptoms and then they were found to have COVID. So we found, again, a relatively high rate of people, like Brian had mentioned earlier, that were totally asymptomatic and felt just fine. Many of them never went on to have symptoms, and then some of them did go on to have symptoms. So very much what we are experiencing now. The average age of sailors on an aircraft carrier was 27 years old. Most are men, 90% are enlisted. Most of the cases were among the enlisted because of the berthing situation. It's very crowded in enlisted quarters. 1.7% of the crew, or 23, wound up being hospitalized. 4 of them went to the ICU and one died. So out of the entire crew, we had 1 fatality, which was far less than what was expected by the medical staff on board. And interestingly, we found that there was only one COVID infection among the 97 members of the medical department, and it attests to how well the PPE was working at the time. And again, this is happening March, April, May timeframe, fairly early on in the pandemic, where we really weren't certain how fatal this might be or how effective the PPE would be, but the PPE was very effective. This is how the distribution of positive cases went. You can see that, initially there were fairly few cases, and then this just exploded, and we peaked early April, and then had a little bit of a decline, and then an upsurge again in around May. But this was what the distribution of cases looked like among the sailors that were affected. Interestingly, as you look at the number of symptoms, or the kind of symptoms that were there, very similar. Headache, cough, nasal congestion, and altered sense of taste and smell were very common. By way of disclaimer, I was myself infected with COVID earlier in November, and these were exactly my symptoms. And I initially tested negative for COVID and then subsequently tested positive after I lost my sense of taste or smell. And I can tell you again, kind of what Brian was saying, I didn't think that I could possibly have COVID. I thought I felt too well. These symptoms were so mild and so non-specific. It's very deceptive, but be alert. You just may not know. But most of our sailors had symptoms in this category, and I went through the same thing, and I thought that was very, very consistent. What did we do for some of the sailors on the island? We were, in addition to providing for their medical needs, we ran sick call, distributed medications. We actually, brought meals to them. Being in quarantine and isolation like this with not the best access to the internet, it was really depressing for people to be stuck here for weeks and weeks like this in these conditions. So chaplaincy and mental health support were really quite critical. So in addition to monitoring all of the infected personnel down there and setting up our field hospital and running that up here, we also set up a permanent facility on the naval base. So we transferred all of our equipment and supplies to a permanent installation here in the event we do need to go back or assist another ship or provide help to the civilian population. The end of the mission really came around June. The Roosevelt returned to duty and conducted her trials. Most of her crew was able to return back to the ship by mid-June, and then those that had not gone, we were able to return back around the end of June. Most of the crew did rejoin the ship and were fine. There were about 100 folks that still had lingering medical issues that were not able to rejoin the crew. By being able to handle the 1,300 folks here and manage their issues, we really offloaded Naval Hospital Guam and the civilian installations on the island and let them take care of their own residents and the military dependents there. So that was, I think, important for us to not burden the local healthcare facilities with our military personnel, but rather to really take care of our own, which I thought we were able to do. So for those that might have followed the fallout from this, there are a number of things that actually happened on board. And you can read this and get a copy of this online if you're so inclined, the report of the investigation regarding the Roosevelt. There were a number of things that could have been done better. The captain of the ship was relieved, as many of you may know. The admiral who was assigned to the strike group, his promotion was withheld, and the senior medical officer aboard the Roosevelt was also relieved. In the Navy, when you get to this level of rank, these are pretty much, unfortunately, career-ending maneuvers, and so most folks will find that this is the end of their career now. The Navy began to reconsider whether or not to allow port of call into certain coastal nations, especially if they are not as transparent about the degree of COVID in their nation as they should be. Many updates to practices and policies regarding how to manage infectious disease outbreaks aboard ships. There are volumes and volumes being published about this to really retool our Navy. And then the entire TR incident is being used as a case study in Navy leadership courses now on how to maybe do things better. The captain was criticized for the release of the letter that made its way into the San Francisco Chronicle because he transmitted this on an unsecured network. And as the captain of a capital warship, transmitting information about the functionality of your ship and the health of your crew and your ability to fight, it really is, it's really not what is expected of a naval officer. He was criticized for not slowing the spread of the disease. Aboard the crew, some of the crew that were infected initially were put into isolation, but were released after a few days because it was felt that quarantine wouldn't be helpful, and also that it was probably among the crew and too late, and quarantine and isolation wasn't going to help, which in retrospect was probably a mistake because this allowed the disease to spread among the crew. There was a tendency to want to hold and not let the crew off the ship over concerns that single rooms were not available for all of the sailors on the ship. And so this also probably delayed getting the crew off, which probably also facilitated spread of infection. So this was the criticism that the Navy had for the captain. The Admiral Baker, who was also on board the ship, they felt that he and the CO of the Roosevelt didn't coordinate and communicate very effectively, and that also the senior medical officer aboard the boat had taken kind of a worst case scenario type of point of view in providing his medical guidance to the captain. Personally, I feel bad for the captain of the ship, Captain Crozier, because he is not a trained medical professional and relied heavily on the advice of his own medical department. And I think that, again, early on in the pandemic, when things were looking their worst and things were looking their darkest, the information that he was given about what would happen if he didn't take certain actions, I think he had to act on what was available to him. The senior medical officer was fairly convinced the entire crew was infected and that the mortality was going to be very high. And this kind of drove the decisions that were ultimately made. What may not be widely known is that the letter that ultimately was leaked to the San Francisco Chronicle, this letter originated in the medical department on board the ship. The medical department had all signed a letter, including the senior medical officer, and presented the captain with an ultimatum that if he didn't get the crew off the ship or do something, they were going to send a letter to the press. And this ultimately, I think, was what caused Captain Crozier to write his own letter and try to get some action from the chain of command. What is known is that the captain sent his own letter, the one that made it to the Chronicle, to about 7 people, including the senior medical officer. A few minutes after this letter went out, the senior medical officer sent his own letter out to about 160 people outside the chain of the command, which again, in the Navy, you just cannot do. And one of the key reasons he was relieved. So what did the Navy learn from all of this in terms of its ships? Now for ships that are going to sea, the crew is sequestered for 14 days and all of them are going to be tested before they actually go on board the ship. Unfortunately, shore leave and port calls need to be restricted so that there's minimal contact with the civilians. We continue to use in the Navy masks, social distancing, hand hygiene, and clean the spaces, just as we do here at the hospital. So all of good advice still in place, but certain things that we need to do more for folks at sea. This is us here returning to California at the end of July. And with that, I will stop talking, and we are at 0900. I'm happy to take any questions at this point. So thank you very much.
Thank you, Captain Damrose, for that amazing presentation. It reminds us that while we're here at home taking care of patients, but also each other and our families, you're focused fully on other people. And so thank you so much for your service. I think that goes without saying.
Thank you.
And thanks. If you're okay, we'll go about 5 minutes over. We have a few questions here for you. Dr. Rajak asks, thank you for your very informative and inspiring talk, Dr. Damrose. I come from a military family as well as have often thought about working as a physician in the Army Reserve. Do you know if there's an age cut for being accepted as a physician to work in the Army Reserve?
You know, that's a great question. Usually the age cuts are around 62 to 63, but there are waivers available for physicians. And so I know individuals that serve and affiliate at that age. I have a good colleague who's a neurosurgeon, who was actually a neurosurgeon on staff here at Stanford, who joined us around the age of 60 and is still serving. So absolutely yes, and I'd be happy to talk to you about that if you'd like.
Wonderful, thank you.
Mm-hmm.
Dr. Weinberg asks, given the key role of battlefield medicine in the development of triage, what are the USN plans for COVID if cases and severity were to exceed capacity? And what is the relevance of these plans to civilian medicine?
That's a fantastic question. I can tell you that there are a number of plans, if need be, to redeploy medical reservists, not only in the Navy, but through all of the branches around the United States, if need be. My unit that I'm assigned to right now, one of my reasons for being away this past month was to get that unit ready to deploy again if need be. So the military has considered how to leverage the current resources around the United States if we need to do this again. There are some limitations, I think, as we saw, like the hospital ships. Again, you know, if you bring COVID aboard a hospital ship, it will spread fairly quickly. And so there are some limitations there, I think. Some of the lessons that we've learned, I think, from the military would be how we might handle an outbreak on a cruise ship, for example, going forward. And I think the most important thing that we learned from this, and certainly that I learned, is that, especially in the military where you have young, healthy people, the mortality is going to be different than, say, on a cruise ship, which is made up of retirees. So these types of lessons and how aggressive to be in handling different patient populations, I think, is a lesson that we've learned from this mission.
Thank you very much. Dr. Harrington had a question for you.
Yeah, first off, Ed, I want to thank you for one of the best grand rounds of the year. And like Errol, I want to thank you on behalf of the Department of Medicine for your service. This was really terrific. You know, your pictures of your family during World War II reminded me of my Italian immigrant grandfather, who at age 30 after Pearl Harbor joined the Navy as an enlisted man and ended up as an engineman in the Pacific Fleet. And he's fought in many of those battles that you made reference to. So it was I too had the family memory. So thank you. My question really has to do with the arc of your naval service. And what about your naval service, whether it be leadership or medicine itself, has helped you in your Stanford job?
Thank you, Bob. That great question. One of the things they say about leadership in the Navy is that, when asked to lead, lead. And it seems somewhat trite to say that, but the point is that there's, if not you, then who? One of the things about the military that I like is that there is a fairly clear chain of command. And I think that has actually helped me in my hospital leadership, in the sense that when you're asked to lead, you may need to deal with some unpleasant and uncomfortable situations, especially giving counsel to people that are not performing well. And I think learning how to have difficult conversations and how to actually maybe step forward into uncomfortable positions has been very helpful, and is and something I've taken away from the Navy and brought back to my role at Stanford, so to speak. I've also had the role of being of managing the equal opportunity sexual harassment type of programs for my unit. And I've gone to classes to learn how to do that, and that's been a benefit to me, I think, as well, and is something that has complemented my civilian role as well. So the Navy has given me, I think, more than I've taken from the Navy in helping me develop as a leader, and those are some of the things I think I've taken away, Bob.
Great. You were having spent a lot of time with you when you were the chief of staff, you were an absolutely fantastic chief of staff and dealt with, I know, some very difficult issues. So again, thank you for your service on that behalf as well.
Thank you so much, Bob.
Dr. Damrose, maybe one more question here. Sure. Assuming the White House is like a contained ship, how long will it take to decontaminate it for COVID-19 after January 20th?
That's above my pay grade, Errol.
Yeah, one other question is interesting. What is the history? I Googled this a little bit. It's interesting. What's the history behind giving vessels a feminine pronoun? Look, do you have any?
Oh, well, I think that's a British tradition that we took from the British Navy. Why? That's a great question. Why if sailors go to sea and call their vessels she or her? It's an old tradition. I know we've taken that from the British Navy.
I was just Googling something about treating them as protecting the crew as a mother or goddess of sea. I don't know if that resonates.
I think that does.
Dr. Damrose, as we close, I just want to acknowledge a lot of different comments. Thank you both for your service and for an amazing presentation. Stacy Service said thank you. She said something about go Bruins, but I think it was a typo. I think she meant go Cardinals. Thank you so much again for everything, Captain. And again, thank you for your service. Thank you for everybody who's sticking around, and for our panelists for answering all the questions. We will continue to keep everybody updated. Of course, it's a very busy time for that. So please give us your feedback as well to make sure we're communicating effectively throughout the next couple months. Thank you, everybody. Be safe and have a good day. And good luck for match day today for the fellows.
Thank you.
Thank you. Bye-bye.
Bye-bye.